Now, you've all heard the hype about electronic medical records. You can barely walk around this floor without people asking you how to better implement your EMR. But really what it all comes down to is your patients and the quality of care. We really need to address the fundamental questions that EMR can use to help improve the quality of care and ensure we get paid appropriately with all these different payment systems. So, the EMR has widely been touted as an essential tool to improve the quality of medical care. We will explore how the EMR combined with an integrative enterprise data warehouse not only enables the high quality and coordinated care, but it's also critical to enabling population health management in the brave new world of payment reform. So today's presenter is Dr. Mark Dente. He is uniquely positioned to offer some ideas on this. He started his informatics career over 18 years ago after he graduated from Boston University School of Medicine. And he's really been focusing on new approaches to increase the patient safety and to drive physician adoption of technology and to create new methods to implement evidence-based medicine. So today his responsibilities include applying domain expertise in informatics to drive comparative effectiveness research, strategic evaluation of emerging technologies for the healthcare portfolio, and developing GE's clinical informatics research direction globally. So, Dr. Mark Dente, CMIO of GE Healthcare, take it away.
Great, thank you. Thank you all. Thank you for taking the time to share with us the next 15 minutes or so, 20 minutes or so. Really am excited about what we're doing and how to really think about our patients' care, because at the end of the day, that's what we're all here for. Let's not make sure that we don't lose sight of that. At the end of the day, it's how are we going to take care of our patients? How are we going to understand the impact of what's occurring with payment reform and the brave new world that means for us? And there's a lot of pressures being put upon us. There's financial pressures being put upon us. Our population's aging. Bluntly, the demographic of clinical staff is changing. You know, when I graduated, they cited I went to Boston University, 30 pounds lighter, full head of hair ago. And when I graduated, about 50% of us went into some type of primary care, about 50%. In the stats for 2010, we're down to about 22%. So we have to think differently of how we're going to deliver care in the future. Now, when we start to think about these really transitions that we're dealing with here, they're really going to start to revolve around the prevalence of chronic disease, how we're going to manage that chronic disease, how we're really going to start to think about the different payment models and the reimbursement models that are coming about, whether that's bundled payment with shared risk, whether that's episodic payments or global payments in the future, the ACO model and all of that. What we do know is that we went from a world where I used to take care of my patient to now I still have to take care of my patient, but really we are all now in the population health management business. And what is the electronic medical record going to do to help support that? And that's what's really exciting about what we've taken on. As we start to think about coordinated care and improvement in quality and ensuring privacy, some of the fundamentals we also have to understand about is how are we going to engage our patients? Part of the world we're moving into is to make sure that our patients understand and have transparency to their care. So we have technologies like our Patient Online and other technologies that allow our physicians to interact with our patients, that allow our patients to be able to interact with their own information that is their information. And we've seen wonderful results. Pragmatic results, like about a 75% reduction in no-shows from patients that were able to schedule their own appointment and make that on their own terms, to the ability to really start to think about population health management. Now, we're unique. In our introduction, we talked about something called an enterprise data warehouse. So not only is it important to have your electronic medical record, you want the data streaming off of that electronic medical record to go into this enterprise data warehouse, so now you can start to do analytics on that information. We clearly need to go longitudinally across our patient, especially in a coordinated care model, but we also have to start to think about what occurs when we have to go across patient segments, because we're now in the population health management business, and how to do that. What's really exciting, by the way, is when we really start to think about the MQIC, Medical Quality Information Consortium. That's our enterprise data warehouse that is integrated with our Centricity Practice Solution, our electronic medical record and fully integrated billing technology. Why is this so critical in the world of population health management? This is critical because it allows us to kind of go through and say, how do we take that information, not only on this one patient in the medical home concept, how do we work coordinatedly with our colleagues in healthcare delivery, all the way from the home and remote monitoring to the ICU, but also now how do we manage this population of payments in this brave new world of payment reform, where we're looking at bundled payment and accountable care organizations and paying for value. Well, what's really interesting is we actually have 40 different specialties, type specialty forms and everything embedded into our electronic medical record system. That allows us to have a really interesting cross-section of demographic of clinical providers. In fact, we have about 24 million anonymized lives in a HIPAA-compliant database that we do clinical research with today. Now, historically, we started to do this about 6 years ago, and we recognized that from an informatics perspective, you can't just put data into a database and expect to get information out. What you have to do is start to normalize this data. What do we mean by that? If I take something as simple as blood pressure, how many different ways can you say blood pressure? Lying, sitting, standing, left arm, right arm, exercise, no exercise, drugs, no drugs. There are 25 different ways of saying blood pressure. Well, for data to be of value to do research with, we have to start to normalize that. So the research side of this, the analytics side of this, can start to go back through and look for patterns and be able to report against that in a pay-for-quality world that we're moving into. When we start to think about that right now, we have over 400 of our Centricity customers actively engaged in this clinical consortium that are doing research with us. What was really exciting, though, with our latest release of Centricity is that now, right at the desktop, it's no longer an asynchronous model. The provider, right then and there, can look not only at an individual patient across different caregivers and provide that right back to the desktop, but they can now also look across their patient population and see what do they need to do from a quality perspective in real time as they have the patients in front of them on that daily basis. This is just a representation of what we're doing. So what can you do when you have great data? So you'll hear that a lot about GE. Clearly, we have to make sure that we have highly functioning, workflow-enhanced products so our clinicians, our physicians, can see a patient extremely efficiently, do that great care that we have to do for them. But what we also want to make sure is that when you have great data like this, we put it for use not only for our own benefit, for our institution's benefit, our own hospitals or integrated delivery networks or practices, but also what can we do as society. So this was a project that I actually had the personal privilege of helping to design. So this was something we did with the Center for Disease Control, and it was a biosurveillance project that actually looked at the ability in near real time, within 24 hours, to stream to the Center for Disease Control influenza-like illness, along with comorbidities of patients, and then we were able to start to create outbreak scatter diagrams of where the H1N1 was actually propping up, and then how to really think about treatment of those, where to direct vaccines, and all of that. In essence, our technology right now today, in essence, has a safety surveillance monitoring technology embedded in it. And when you start to think about that, we can start to say, hey, what can we really do on a geographic level, on a national level, or down at my local level in terms of where I'm going and how I'm going to approach my care of my patients. The last thing I want to talk about how electronic health record system is going to really enable great patient care is when that is linked with other data. So again, that theme of consistency of I have to take care of my patient, but now I need to gather as much information in the medical home concept of providers as we go forward, and that's where our interoperability solutions come in. The ability to come in and do coordinated care, to integrate that information across the care continuum, and the ability to really start to think about how meaningful use stage 2 and stage 3 is going to be delivered, and then how we're going to be able to help partner with you to make sure that we meet those challenges. When we start to think about the 5 big buckets, and there really are 5, it's one about interoperability, it's transparency of communication and care transparency for our patients. Clearly the analytics is going to be strategic going forward. Accountability, all the ability to, now that we're in the new world of payment reform, how do we manage all the contracts with the different payers and the different plans, and how does that relate to the hospital, to the independent practice, to the large multi-specialty practice, and then clearly population health management. Aging population, we need to start to think about what's going to be the future of healthcare. 10 years from now, will most of our clinical data on our patient come from the bricks and mortar of our encounter, or will it come from outside the bricks and mortar of our encounter and how a patient is actually seen? Think about that. If I can now start to monitor my patients remotely and bring that forward, what can I really do in the future? So this is research that we're actually doing right now. It is research. I think when you start to look at electronic health record systems, interoperability solutions, and all of that, you have to think about what I need today to meet my demand, to meet my business needs, to meet my patients' needs. But these are long-term relationships. You should be thinking, gee, is the person that's actually supporting my technology thinking about the future? What is their position on genomics and proteomics? How does that impact the ability of a patient to be seen? This is work that we're doing in Alzheimer's disease in predictive modeling. So how do you really kind of get in there and try to find signal within these large elements, again, within the electronic health record, the enterprise data warehouse, for the ability of a patient to come in and look for that analytics team going forward. Well, it's a quick story of electronic health records and where we believe that we're trending and we're excited about. I want to thank you all for taking time and spending some time with us, and follow us on Twitter and get in the conversation. And I hope you have a great show. Enjoy yourselves. Thank you so much.